Hello everyone. Today I'll be doing the test and discussion of the topic lymphoproliferative disorders, and it will be integrated approach in which I'll be covering all the subspecialties which are relevant to my talk. If you know this much, a good amount of everything about this topic will be clear to you. Okay. So before I really go to this question one, I must give you the basic concept about what you mean by lymphoproliferative disorder. Okay, so for that we'll talk about embryology first, without which you will not understand what is lymphoproliferative and what is myeloproliferative. Already I have done a topic of myeloproliferative test and discussion. Those of you who have not seen, you can see all my previous tests, including myeloproliferative disorder, in the YouTube. So first we talk about embryology. We have pluripotent stem cell. Everybody knows that pluripotent stem cell is the main cell in the bone marrow from which the cells arise, all the cells. Well, it gives rise to lymphoid series. It gives rise to myeloid series. Myeloid series predominantly give rise to RBCs, platelet, P for platelet, and a granulocyte, which include neutrophil, basophil, eosinophil. It also give rise to monocyte, M for monocyte, and they also give rise to, this pluripotent stem also give rise to monocyte, macrophages. Okay. So when we talk about the disease of this series, like RBC, it is polycythemia vera. It's the malignancy of RBC. The malignancy of platelet is essential thrombocythemia, and malignancy of this is CML. Polycythemia vera, essential thrombocythemia. Sometimes they also call it to be essential thrombocytosis, etc. So these polycythemia vera, ET and CML, they all arise from the myeloid stem cell. That's why they are also known as myeloproliferative disorder. Okay, this we studied in the previous test and discussion. Well, we come back to lymphoid series. It gives rise to B and T lymphocytes. Now, whichever malignancy which arises from these, particularly from the B cell, like what we get, multiple myeloma, chronic lymphocytic leukemia, and hairy cell leukemia. HCL is hairy cell leukemia. These malignancy which arise from B cell, these together are known as lymphoproliferative disorder. So as today's topic is lymphoproliferative disorder, so I'll be discussing with these three diseases in particular. But again, what is common in this? Of course, there are all different type of pathology, but there is something common. There are two things common in this. So the two things common in these are, number one, all of them, they occur in elderly person, above 50, 60, 70 years. So definitely the clinical applied is, it is not a disease of young people or pediatric age group. No. That means the clinical applied is, you get a question, a 10-year-old boy come to you, a 20-year-old young man come to you, and you are making diagnosis of lymphoproliferative. You are wrong. This cannot be. It's not a disease of the young people or the pediatric age group. So in all the question will be, first thing we'll be looking for the age of the patient. That has a lot of relevance, the point I told you. Second, in all these three diseases, it is small lymphocytes are involved. So far we discussed that they are the B lymphocyte are involved. But what type of lymphocyte? Small lymphocyte. The large lymphocyte will not be involved. Again, this will be very, very important clue when we're looking into the peripheral smear in some of the question. With this small introduction of the basic concept, and now we are clear about it, what do you mean by the lymphoproliferative disorder? We go into the first question. Okay, so we are getting a 65-year-old, well, is an elderly man, so now we have a relevance. It comes with generalized unwell, not feeling well, doctor, pain in the back and the leg, and he is slightly confused for the last few days as told by his wife. The blood, and if you look into the biochemistry, blood urea is raised, creatinine is also on the higher side. That means there is some element of renal failure as evident by the lab reports, and patient has anemia 9.7 gram. Total protein, albumin is normal 3.31 gram per liter, or you can say 3.1 gram %. This is normal, it's absolutely normal range. But total protein is 84 gram, or we can say 8.4 gram % or per DL. Definitely it is much more. Calcium level is again raised 12.42 milligram %. It's raised. Normal is 9 to 11. Okay, it's a raise even. Okay, so what we are getting in nutshell, we are getting renal failure element. Yes, we are getting anemia. Why? The hemoglobin is reduced, and we are getting increased protein and increased total protein, and we are getting increased calcium. This is what we are getting it, right? With this background, what the most likely diagnosis? The answer is multiple myeloma. Why this the answer? Why not others? Let's look into the explanation. Okay, multiple myeloma. Well, if you look into the reports, one of the standout result is high calcium level. That I told you, calcium level is much more than what is expected in this patient. So hypercalcemia is there. So we are getting a definitely entity, that means so we have to talk about the differential diagnosis of only those things which cause hypercalcemia. Agreed? Now remember the two most important cause of hypercalcemia. Of course, if you look into the books, a huge list of hypercalcemia is there, but invariably nothing should be discussed before we discuss two important causes of hypercalcemia. They include malignancy and primary hyperparathyroid. They are the two most important causes which should be always thought first before you go into any third diagnosis. Now I said malignancy. In malignancy, breast cancer, squamous cell lung cancer. It itself is a universal question. Why it is so important? It needs a discussion, so we spend some time. We know very well in lung cancer, lot of endocrine manifestations are there. In any case of lung cancer, all these endocrine features which occur in lung cancer, they occur in small cell lung cancer. And what happens in small cell lung cancer, there can be hyponatremia, there can be Cushing-like feature, Cushing-like feature. This occurs due to SIADH, syndrome of inappropriate secretion of ADH. Cushing syndrome occurs due to ectopic secretion of ACTH. Okay, and one more thing which is not known to 99%. In small cell lung cancer, hypocalcemia occurs. This is due to calcitonin. But point to be noted, well, there are so only one entity, only one endocrine entity which occurred in Squamous cell, that is hypercalcemia. And this occurs in squamous cell lung cancer. Oh, squamous cell cancer. And this is due to PTH related polypeptide. In fact, in all malignancy where, as I told you, hypercalcemia occur, it's not due to PTH, but PTH related polypeptide. In fact, in these cases, PTH level is actually reduced. PTH related polypeptide are increased. Point to be noted. So we are clear about, so we got lot of extra edge question on these words, squamous cell lung cancer. And now you are clear about it. Lung cancer alone is not sufficient. It has to be squamous cell. Renal cell carcinoma, multiple myeloma, lymphoma are some of the malignancy. Well, not to forget, in our answer, we made a diagnosis of multiple myeloma. We'll talk more about this thing. Second entity is primary hyperparathyroid, which is due to increase PTH secretion. And malignancy, they are due to PTH related polypeptide, PTH related polypeptide. So we are clear about it. So in these cases, we will measure PTH. Here we talk about PTH related polypeptide. So we are very clear about it. But one more thing. In all these conditions, hypercalcemia occur. That means we are, as I told you in the very beginning, our discussion pattern is reduced to a limited number of conditions which lead to increased calcium. Now, increased hypercalcemia. But in our patient, we are getting some two additional finding. We are getting finding of renal failure. Why? Urea creatinine is increased, and we are also getting finding of increased total protein. So this increased renal failure and increased total protein occur only one condition, that is multiple myeloma. So all these conditions, as I told you, they can lead to hypercalcemia. They can all lead to hypercalcemia, right? Which fit into the DD of hypercalcemia. But there's only one condition which can lead to renal failure, and especially increased total protein occur only in multiple myeloma, in no other condition. So we are very clear about it. We are very clear about it. We are getting patient of renal failure. So friends, you can note down the golden line to remember. Golden line to remember is this. If you get increased calcium, if you get feature of renal failure, if you get increased total protein, then it is nothing but multiple myeloma. Very simple. In fact, I can even make it more simple. Of course, I've written it. But even if you are getting these two things, increased calcium, increased total protein, that again indicate multiple myeloma. But I have deliberate, of course, renal failure is one more element. Okay. Now there is one more golden line. Even this one more golden line is golden line to remember. Increased calcium, renal failure. This is again multiple myeloma. Come on, how come? That means, friends, if you are getting a case of chronic renal failure with hypercalcemia, it is multiple myeloma. Golden line to remember. Why? Hypocalcemia is a feature of all type of chronic renal failure. So only one exception to this rule is multiple myeloma, where patient can have renal failure with hypercalcemia. So just look, that's why I said if you are getting these three words, 99.999% you are dealing with multiple myeloma. So things are very simplified, I told you. So we come back. So let's talk more about multiple myeloma, basic concept, additional knowledge for you. Well, it's a neoplasm of the bone marrow plasma cells. And again, we go to now we talk about basic physiology. We are well aware that plasma cells are derived from B lymphocyte. B lymphocyte, they make plasma cell, and the basic physiology of plasma cell, these are the cells which produce immunoglobulin. So we can say they are the immunoglobulin cell. So this is normal physiology. So now in multiple myeloma, they are abnormal plasma cells are there. So as we know, that's a definition of any cancer, the cells, they are abnormal. So now this abnormal plasma cell, they produce immunoglobulin. Yes, it is the duty, it is the purpose of creating immunoglobulin. But what the problem? Problem is, although they are making immunoglobulin, but they are useless immunoglobulin. They don't work, they are not effective, but they cause increased total protein. So they contribute to the number, but they don't contribute to the efficiency of the work. Rather, they are useless. So that means we have a one city or one village with a large number of people are there. The population is very high, but none of them is working. They are all sitting idle, useless people. So that's why we are getting useless immunoglobulins are there, but the number is increased. So increased total protein, this is the basic reason why total immunoglobulin is reduced. But I like to add one more thing. Well, the plasma cells, yes, most of them, they are becoming abnormal plasma cell. Okay, I'm making double figure. They are abnormal and they are producing immunoglobulin, but there again, useless immunoglobulin is there. But some of the plasma cell are normal also, single circle. They are producing normal immunoglobulin. Okay, they are producing. But what I want to convey, the number of abnormal useless immunoglobulin is very, very high. And number of good immunoglobulin is much lower than the normal value. Now come the clinical applied. The immunoglobulin level is, good immunoglobulin level is reduced. Okay, so the clinical applied, these patients are prone to various infections. They are prone to various infections, particularly UTI and particularly pneumonias. Okay, pneumonias. So now we understood why these patients are prone to these recurrent infection. So with this background, we move further. We got a lot of question. We got a lot of physiology question, including immunoglobulin, which are getting produced by the normal plasma cell, and of course, abnormal immunoglobulin from the abnormal plasma cell. Age 60 to 70 years, that qualified, justified our statement that it is a disease of elderly people. So now one more thing, plasma cells are there, as I told you, they are producing monoclonal proteins. What do you mean by monoclonal protein? We know very well that we have a IgG, IgG. What type of immunoglobulin? G, A, M, D, E. There are 5 types of immunoglobulins are there: IgG, IgA, IgM, IgD, IgE. But these cells, plasma cells, they produce only one type, maybe G or A. These are one which are most commonly produced, either of them. Of course, G is much more than the A. But whatever may be, it will be only one type, so-called. That's why we call it monoclonal. You will not that in one patient you will get G also, A also, M, D. No, only one. So in multiple myeloma, IgG or IgA occur, and this increase occur in Waldenstrom macroglobulinemia. IgM will be raised. Okay, so we are clear about it. So usually IgG or IgA are in multiple myeloma, and this you can see in the serum as well as in the urine also. If you see in the urine, we call as Benzone proteins. That is that is immunoglobulin make in maybe like a light chain. Okay, that if you see in this benzone proteinuria is see in multiple myeloma. Increase plasma cell in the bone marrow, but now by now your concepts are clear. Let me discuss more. Normally in bone marrow, the plasma cells are less than 10%. Okay, but in these patients, in the particular in multiple myeloma, the bone marrow plasma cell are usually more than 30%. The more than 30% plasma cell in the bone marrow is highly suggestive of multiple myeloma. Okay. Now so that means now you know the importance. Now we talk about pathology. In the pathology, that pathology, when you do a bone marrow aspiration, you are going to get lot of plasma cell. Well, now we come to radiology. Radiology, quite possible that most of the time, previously we go for X-ray of the various part of the skull, various part of the bones. We get lytic lesion. What we get is lytic lesion. This is a radiology picture. Okay, but however, nowadays we prefer to go for MRI. Okay, so in this slide, I covered three important subdivisions. One is immunology. In immunology, we found there is increase mostly IgG level or maybe IgA. And even this immunoglobulin may be there in the urine in the form of benzone protein. In the pathology, we get increased plasma cell. How much? More than 30%. And radiology, we get lytic lesion. That we can see by X-ray, or better is, of course, MRI is a better investigation to look for the lytic lesion. So three subjects we covered in this particular slide. So I talked to you regarding X-ray to see what we get. We get raindrop skull. Let me show you first. Oh, look, it's beautiful. I think raindrop skull, you will never forget if you see it once. It looks like that rain has fallen and you get some mark on the floor that you must have seen. So what is the raindrop skull is? Presence of multiple well-defined lytic lesion, punched out lesion, the usual word. If you get a punch out lesion in the skull X-ray, 99.9% you are dealing with multiple myeloma. Key word to remember. And remember, they are usually seen in skull better, but you can see in other parts also. So now again you look into this beautiful punch out lesion throughout the skull is raindrop skull. So we got about radiology, immunology, pathology. Now let's talk about biochemistry. Hypercalcemia occurs in patient of multiple myeloma, and we will correlate this biochemistry with the pathophysiology also. Let us integrate these two. Now why this hypercalcemia occur? Due to increased osteoclastic bone resorption. So let me go back to the histology of the bone. Okay, so now we correlate this osteoclastic activity which causes the resorption of bone. Okay, but what is this osteoclast is there? Let's go into histology of the bone. Histological examination of bone, then to understand better. We have a central canal in the bone, central canal, and around this central canal are lacunas are there. In the central canal, we have a cell called osteoblast. It is a bone forming cell. It creates the bone. It's a bone forming cell. And here only we have other cell which is called as osteoclast. It is a bone resolving cell. What do you mean by bone resolving cell? At any given time in the adult bone, around 5 to 10% bone is under constant repair. Whatever bone is damaged, broken down, that is removed by the osteoclast and that is repaired by the osteoblast. So it is a bone forming cell, it is a bone resolving cell. And around this central canal are lacuna, which are empty spaces. They contain a cell which are known as osteocytes. They are the one which maintain day-to-day activity of the bone. They maintain day-to-day activity of the bone, and these cells, they are united to each other via dendrites. Okay. So we got three types of cells: blast, class, and site. So this is a bone forming cell, bone maintaining cell, and the bone resolving cell. Just like in Hindu mythology, they say Brahmaji is the creator of universe. The osteoblast is creating the bone. Vishnuji is the mentor of universe. We have an osteocyte which maintain the bone. And the one which remove all the bad element from the earth is called as Shiva. So we have an osteoclast which remove the bad bone. So creator, mentor, and destroyer, Brahma, Vishnu, and Shiv. Throughout your life, you will not forget the normal histology of the bone. The bone creating cell is osteoblast, bone maintaining cell is osteocyte, and bone resolving cell is osteoclast. Now, what are the clinical applied of this basic histology? Okay, well, now this osteoblast in one of the question. So when we do bone scan, when we clinical applied, the clinical applied integrate. Now this we integrate this histology with the radiology, or so-called radiotherapy. Okay, the clinical applied. This osteoblast, when we do bone scan, when we use radioactive material, it is taken up by the osteoblast. Now, in multiple myeloma, osteoblast activity is not increased. Hence, bone scan is of no value in doing investigating multiple myeloma. This is the question in the this come in discussion in the future question also. Now, osteoclast is the one, the clinical applied, is the one which causes resorption of bone. In multiple myeloma, there is increased activity of osteoclast. And that is the reason why hypercalcemia occurs. Okay, hypercalcemia occurs, and the one which is, as I told you, in multiple myeloma, hypercalcemia occur. So now let's correlate this with the osteology. What happened in radiology also, more of this phenomenon. When it is trying to remove calcium from the bone, these lacuna become bigger and bigger. They become bigger also, and of course the bone is getting removed, calcium getting removed. So that's why there's a hypercalcemia in the peripheral circulation. But radiology, you get lytic lesion. Lytic lesion, what I mentioned in the previous slide, that you like to do the skeletal survey, maybe by X-ray, maybe by MRI, and I show you picture of so-called raindrop is nothing but lytic lesion. So now you are much wiser. So we in this one particular word, you get question on biochemistry, radiology, pathology, pathophysiology, lot of question, and orthopedic also, of course. Now, why this resorption is occurring? By local cytokines, interleukin-1 and tumor necrotic factor, which are going to stimulate the osteoclast. Okay. And of course, they are released by the myeloma cells. Well, other less contributive factors are increased renal tubular calcium reabsorption. We all know very well. Let's read the physiology. We all know that calcium is reabsorbed from the proximal tubule. So in these patients, there is excess of calcium reabsorption from the proximal tubule induced by PTH related polypeptide. So you can nicely correlate with the physiology also. And elevated PTH related polypeptide is also contribute to bone resorption from the bone as well as from the kidneys. So ultimately they also contribute to the hypercalcemia. Well, other option that we saw in this, none of them lead to hyperproteinemia. So I told you the golden one to remember is hypercalcemia, increased protein, and that is nothing but multiple myeloma. Question number 2. 59-year-old men, fatigue, chronic back pain, pain occurs more during movement, and tenderness is there in the bone. There is normocytic normochromic anemia and hypercalcemia. Bone marrow shows biopsy is done. What we are getting certain cells, the bone marrow. Lovely question to look into this. What clinical finding, medical wise, the clinical part is either low backache. He has hypercalcemia, biochemical normal, and anemia is there. And some cells are shown in the peripherals, in the bone marrow. Okay, this patient is greatest risk of which the following. So now he say, that means beautifully framed question. He never mentioned anything about the diagnosis, but he just gave you a pathological slide, and they want you to know the pathology also. Clinically is bone pain, and biochemically is hypercalcemia, and now are asking what complication? Amyloidosis. Beautiful question. Let's discuss this question. Okay. Explanation. Now this picture is showing plasma cells. Okay. So when we talk about plasma cell, we should know. So now we are talking about pure pathology of the plasma cell. So first I'll give you the finding, then I'll show picture, then you will understand better. Abundance of basophilic cytoplasm. Do I need to tell you basophilic means when we'll be seeing the slide, we'll be getting blue background because of increased basophilic cytoplasm. Eccentrically placed nucleus. That means normal nucleus is in the center. Here you're going to expect nucleus at one corner. So-called eccentric type of picture we get. But one point which is there in all the exams throughout the world is clock phase distribution of nuclear chromatin, so-called wagon wheel. So the key word to be remembered in this particular slide for you is basophilic cytoplasm, eccentrically placed nucleus is there, and we are getting clock phase or wagon wheel appearance of the nuclear material. Now let me show you the plasma cell. Look into this. We can very well appreciate the nucleus is at one corner, is not in the center. Agreed? We are getting Golgi apparatus, nothing special about this. Mitochondria we are getting around, fine. But look into this antibodies. At the moment, this has the relevance I told you in the previous slide, that these cells, they produce antibody. They, of course, they in the normal plasma cell will produce normal antibody. If it is a multiple myeloma, it will going to produce abnormal antibodies. Okay. So what we notice pathologically is eccentrically placed nucleus to one corner. Look into this. Okay. Look into one more. Look into this plasma cell. This is the plasma cell. We notice nucleus is at one corner that we saw in the previous slide. But now you appreciate in this you are getting some clear area. Look into this, total clear area is there. Total white. So we are getting perinuclear clearance is there, and you are getting clock phase chromatin. Clock phase chromatin, look into this. This is much better. Look into like the clock. Look into clock like what we has. So here also we are getting clock like. This is the classical exam question. Very often, so you should remember the three things. Remember, the cytoplasm is looking quite blue. It's a basophilic. And now, look into this picture. Okay. So, we are getting a eccentrically placed nucleus. And we are getting, this is blue colors, basophilic cytoplasm. We are getting clearance, clearing around the nucleus, and you are typically getting all these black so-called clock phase type of nucleuses there. Now let me add to you more knowledge about pathology. Well, everybody knows about this plasma cell, but today I'm sure you got something extra knowledge which is very commonly, and these are the rank number 1 getting question. 99.9% students are not aware of this structure of the plasma cell, and they are the one which can top for any exam in the world you write. Now let me give you some extra knowledge about the pathology. Well, in other to plasma cell, there are certain other type of cells that we see in case of multiple myeloma. Can't afford to forget MOT cell. Note it down. They're also seen in multiple myeloma. You get flame cells. For this, you just got to know the name. MOT cell, flame cell. You get Dusher body and you get Russell body are there. Dusher body and Russell body. So 2 more cell, MOT cell and flame cell. And you get 2 bodies, Russell body and Russell and Dusher body are there in multiple myeloma. With this background, so we are getting a perinuclear zone typically, and this is the one, this perinuclear, they contain Golgi apparatus. Okay, I was talking to you, the Golgi apparatus are there. We have seen in these Golgi layer, Golgi body are there a lot in the perinuclear area, and they create a clearing effect on the near the nucleus. So we learned a lot about basic pathology, a lot of knowledge, and the question was amyloidosis. There are certain sequelae or complications that can occur in multiple myeloma. So let's talk about that. At the moment, I'll talk about amyloid. Very commonly asked question. What type of amyloid? It is AL amyloid. Very commonly asked question. All the exam. Okay. Now what happened? There is accumulation of monoclonal immunoglobulin. Yes, light chains are there. There's the basic pathophysiology of multiple myeloma. Now this is seen as eosinophilic extracellular deposit. Point to be noted, the plasma cell inside they have a basophilic blue appearance. In contrast, and they were inside the cell. Now this is outside the cell, it is pink. So there will be contrast if you look into hematoxylin eosin stain. Okay, but this is not a good stain to be used in amyloid. What we use, I'm going to discuss now. So if you use Congo red, this is the universal question, universal throughout the world, whichever exam you appear, Congo red. And one more, golden line to remember, Congo red stain is amyloid, very simple. Golden line to remember, if you are talking about Congo red, you are dealing with multiple myeloma. Oh, sorry, you are dealing with amyloidosis. Okay. So when you see under the polarized light, you get apple green birefringence. The classical finding. Apple green, Congo red is amyloidosis. And now, because this amyloidosis can also contribute to renal failure. Although there are many other reasons of renal failure, but this also contributes. Okay. And remember, not only in multiple myeloma, amyloid deposit occur in the kidney, it may occur in the heart also. It can in the tongue also, in the nervous system also. So there are also other things that can happen, but typically they talk about AL amyloid in the renal. Okay, now I will just show you what do you mean by apple green birefringence, Congo red stain. When viewed under the polarized light, It looks that you are looking at the sky. In the sky, there are lots of tiny stars are there, but they are apple green color in contrast to white star that we see in the background of the black sky in the night. You are getting apple green birefringence. Congruent, this line itself is the golden line you are dealing with amyloidosis. Well, other option that we have in the question: cardiac tamponade, heart failure, hyperthyroid gluten enteropathy. Multiple myeloma is not associated with any of these. So beyond doubt, the best answer to this question was amyloid. A 63-year-old woman come with nocturia, dysuria, crippling back pain. CT scan of the spine is showed in the image. Lab has HB 10.2, calcium is high, and increased total serum protein. I think by now your basic concepts are very clear. So we are no doubt about that we are dealing with multiple myeloma. But now why I put this question? Okay, so when you go in the exam, you are well aware now exam pattern is changing. So any exam in the world you appear, they ask a clinical based question like this, any exam. Okay, so the goal, how to attempt the question. You read the question. I have not shown you the option, even I have not shown that. But one thing is there, once you read the question, stop. Make a momentary thought. What is that talking about? He's talking about, in this case, he's talking about multiple myeloma perhaps. Why do you say? We are getting high calcium level, high serum protein level, anemia is there. The three things that we are pointing toward, something to do with multiple myeloma. Yes, now we look into option. Well, we are getting certain finding. What finding is that I'm going to discuss just now. The question is, most likely explanation of total protein. Oh, very smart. He asked a question on pathophysiology. And he is giving a clue of radiology, and he has given certain biochemical marker in the form of that physiology also, that anemia is there. So what he says, and he's asking why and correlating with immunology, what the reason? Increased production of IgG. Why? As the diagnosis goes, do we get any condition where calcium high and calcium is high and there is increased protein? We learn the golden line. If these two are there, we are dealing with multiple myeloma. And we also know the immunology part, that in multiple myeloma we got plasma cells which are going to produce immunoglobulin. So best answer of this is increased IgG protein is there. Okay. Increased production of IgM, no, this occur in Waldenstrom macroglobulinemia. So let's look into each one of them. Increased production of IgG is the one which contribute to increased total serum protein. Okay. So in this case, we are getting most common picture of multiple myeloma. As we discussed, multiple myeloma is a neoplastic proliferation of plasma cell. And the plasma cell, they produce immunoglobulin. We have a normal plasma cell, they produce normal immunoglobulin. We have got abnormal plasma cell, they will produce abnormal immunoglobulin. So most common protein is IgG, or otherwise IgA can be there, but IgG is the most common. So now, as I told you in the very beginning, in these cases, although increased immunoglobulin are there, but good immunoglobulin level is reduced. And that's why these patients are prone to recurrent infection especially by pneumonia and UTI. Okay. Now this increased proteins, this we can detect by serum protein electrophoresis. And when we do serum protein electrophoresis, we will find gamma globulin fraction are increased. that really indicate that we are dealing with multiple myeloma. Now, in this patient has come with a history of nocturia and dysuria, the main problem. And just in the previous slide only I mentioned these patients are prone to UTI and pneumonia. So these two indicate patient is suffering from UTI. Okay. Back pain is a common, you can see in all the questions discussed so far, everywhere low back pain is there. This is due to involvement of the bone. And that we can see. So in these cases, lytic lesions are there. And due to this, they are prone to fractures, especially the vertebral fractures. Vertebral fractures. So look into this. So the keyword are serum protein electrophoresis and crippling back pain, and that can lead to even fracture. Look into this. Yeah. So now you can see. That even this is the there beautiful picture, particularly this particular see, you can see there is a fracture of the vertebra, which is the cause of back pain, or it may even lead to paraplegia if massive fracture is there that can compress the spinal cord. Now let's look into other option. Option A, inability to clear the chylomicron from blood. This is incorrect. Why? This is seen the primary reduced clearance is the primary problem in the type 1 familial dyslipidemia. Moreover, this disorder they occur in the young patient. So in young patient, increased lipid is there, not increased protein. And as I told you, multiple myeloma is a disease of the elderly person. Our patient is an elderly person. Protein are raised, but in case primary dyslipidemia, lipid are increased, not the proteins. This is not the answer. Option B, increased production of albumin. In multiple myeloma, there is increased production of immunoglobulin. Albumin production is normal, it's not increased. So this is not the option. Increased production of clotting factor and acute phase reactant. They are occur in variety of condition, maybe any condition of inflammation, but total protein is increased only in multiple myeloma. Although these are also proteins, but their level doesn't go that high that they are going to increase total amount of protein. So this cannot be the answer. Increased production of IgM, as I told you, it occurs in Waldenstrom macroglobulinemia, and due to high amount of IgM, these patients are prone to hyperviscosity. Okay, so this cannot be Waldenstrom macroglobulinemia. So as I told you, in Waldenstrom, the hyperviscosity feature are there because IgM is a very big size molecule. There is adenopathy, lymphadenopathy, and hepatosplenomegaly are seen. In Waldenstrom, these features are not seen in multiple myeloma. Very, very important point. Hypercalcemia, lytic lesion, renal failure, they are seen in multiple myeloma. They are not seen in Waldenstrom macroglobulinemia. So this possibility is also ruled out. Question number 4. We are getting a 71-year-old woman, elderly lady, fracturing of the femur, calcium level high, BUN level is very high, creatinine is high, hematocrit is low, it is anemia is there, X-ray obtained in the skull is shown in the picture. Oh, I think by now you are the master of the subject. What we are getting, you are getting raindrop type of picture is there. So function of which cell is the primary mutation? What is asking? He never mentioned what the disease. He just give you clue: renal failure, anemia, fracture, lytic lesion, raindrop X-ray, and he just asks, whatever reason it may be, what are the abnormalities going on? It is production of the antibodies, what he says, the cells which are creating the problem. For the function, antibodies, IgG or IgA, they are so-called M proteins. M proteins means any type of immunoglobulin raise, like in this IgG or IgA may be there. So primary pathology of multiple myeloma, I don't need to elaborate. We just had a long enough discussion about pathology and pathophysiology and immunology, increased production of antibodies. Do plasma cell cause delivery of oxygen? No way. This is not a job of plasma cell, it's a job of a hemoglobin. Phagocytosis? No way. Plasma cells are not phagocytic. Macrophages are or neutrophils. And for neutrophils, they are phagocytic, not the plasma cell. Production of bone? No way. That is by the osteoblast. Resorption of bone, this is done by the osteoclast. So even if you don't know the answer, by rule of technique, this is called rule of technique, you rule out other thing. So now we are very sure, of course we knew about that plasma cell, they produce antibody, but at the same time we have comfortably ruled out all other options. So now we are very sure that we are dealing with the answer C is there. Okay. Well, question 5. The previous question, least useful investigation. We have we made diagnosis of multiple myeloma. In multiple myeloma, bone scan has no use. The point we discussed earlier. Why? There is increased osteoclastic activity. Osteoblast activity is normal. Hence, the bone scan is normal in this patient. The point we discussed in the previous question. Okay. Now, let me give you more information, extra knowledge about what are the lab findings. So let's correlate with the pathology also. Increased ESR is one of the classical features. ESR may be even more than 100. Very, very important point. If ESR is not raised, then perhaps it's not the case of multiple myeloma. This line is also written in some of the literature. So now you can see how important is the raised ESR to look for. Rouleau formation, look into this, Rouleau formation, lovely. Peripheral smear, you make a peripheral smear, you get Rouleau formation. What is Rouleau formation? Stack of RBCs. Like many RBCs, they are clumped to each other like this. And this is so-called Rouleau formation is again, I think one of the very classically when we talk about Rouleau formation, 99% you are dealing with multiple myeloma, such an important clue for the answer. Hypercalcemia is a feature, we have enough discussion. Increased creatinine because of renal failure, pseudo-hyponatremia. This is due to increased serum protein, so you get a pseudo-hyponatremia. Anion gap is less than normal. Very, very important point. Well, I have a question for the student to answer. Okay, tell me any other condition know of. In multiple myeloma, anion gap is less than normal. Normal anion gap is around 6 to 12. In multiple myeloma, it is less than 6. So student, write down the answer in your copy. Any other condition you know of where the anion gap is less than normal, you get 15 seconds to think and answer. Those of my friends who will be watching this video as a recorded version, you must stop the video, write down the answer, and then you restart the video. So write down the answer in your copy. Well, the answer other than multiple myeloma with an anion gap is less than normal is parathyroid. Okay, lovely question. Normal serum alkaline phosphatase, why? The reason is here. the osteoblastic activity is normal. Normal osteoblastic activity, so ALP level will be normal. Urine examination will tell you the benzone protein and 24-hour serum protein, that in the protein urea. If you even collect the urine for protein, it will be increased. And test to detect the M protein, we do serum protein electrophoresis, the point what I mentioned in the previous slide also, and that we do by what? Serum protein electrophoresis. You find increased level of IgG or IgM. Again a confusion. One point which we are not clear. Like in multiple myeloma, there is increased level of either IgG or IgA. In Waldenstrom, IgM is increased. All are immunoglobulin. So any immunoglobulin is known as M protein. So M protein can be IgG, IgA, IgM, anything. So any increase in immunoglobulin is IgM or is M protein. Okay, M protein is raised level of any immunoglobulin, including IgM. So IgM is a type of M protein, but all M proteins are not IgM. Point to note it. So remember, in multiple myeloma, M protein is raised, so-called myeloma protein, which is immunoglobulin. So if I ask you, which M protein are raised in multiple myeloma, IgG or IgA? Which M protein is raised in Waldenstrom macroglobulinemia? IgM. I hope things are clear to you. Friends, golden line to remember. Golden line to remember, multiple myeloma is caused by neoplastic proliferation of the monoclonal plasma cell that produce large amount of IgG or IgA1, not both. That result increased serum total protein occurs and calcium level are elevated. They are the golden line to remember. One more golden line to remember, hypercalcemia, chronic renal failure, high serum protein. This is multiple myeloma. Whichever exam you appear, including Viva question also, this is a single golden line by which you can say, oh, we are dealing with multiple myeloma. Okay. One more golden line to remember. In multiple myeloma, you get CRAB. A CRAB, C for hypercalcemia, R for renal failure, A for anemia, and B for bone pain. This is the universal. Throughout the world, this question is asked. If you are getting finding of CRAB, you are dealing with multiple myeloma. This slide and this slide are good, of course, this golden line also. These three lines give the summary of the whole multiple myeloma. If you remember these three slides, you can answer 99.9% question about multiple myeloma. Part 2, lymphoproliferative disorder. We are getting a 65-year-old man, and he has been referred by the general practitioner. Weight loss, 3 months, lethargy, headache, blurred vision, splenomegaly, and lymphadenopathy is there. In investigation, you are getting benzone protein, yes, skeletal survey, no lytic lesion. No lytic lesion. Well, benzone protein is positive. It can be multiple myeloma. But he has no lytic lesion. This one point which goes against the multiple myeloma. Let us see. What is the most likely cause? Waldenstrom macroglobulinemia. Well, again go back. Are there anything against multiple myeloma? Yeah. Oh, yes. Splenomegaly, lymphadenopathy. Now write down. So in multiple myeloma, no organomegaly. So this, and moreover, no lytic lesion. These are all against multiple myeloma. Okay. Headache and blurring of vision. Very, very important point. Lethargy. Why? Lethargy can be there in a patient of 65 years. But headache and blurring of vision really should alarm your thoughts. Let's look into this. Let's read more about Waldenstrom macroglobulinemia. It is an uncommon condition as compared to multiple myeloma in particular. It is seen in elderly person. Yes, our patient is 65 years. It is a lymphoplasmacytoid malignancy. What do you mean by lymphoplasmacytoid? In this, there is increased level of IgM paraprotein. So that what we use again is a type of monoclonal antibody. Only one type of antibody will be there, and that is IgM. Remember, in case of multiple myeloma, it is IgG or IgA. Here we are getting IgM. So in nutshell, the monoclonal IgM paraproteinemia means we are dealing with Waldenstrom macroglobulinemia. Features: systemic upset, weight loss, lethargy. What is there in our patient? Also in the question. But what is most important? Hyperviscosity syndrome. In fact, in case of blood malignancy, they talk about hyperviscosity. You should think about two things. One is polycythemia vera, and other is Waldenstrom macroglobulinemia. The two things. In polycythemia vera, viscosity increases due to increased RBC count. But in Waldenstrom macroglobulinemia, this occurs due to increased level of IgM. The question is why hyperviscosity is much more prominent in Waldenstrom as compared to multiple myeloma? Basic concept. Let's learn the basic concept. In multiple myeloma, IgG or IgA are increased. In Waldenstrom IgM level are increased. But IgM is a very big molecule. Very big molecule. Definitely bigger the molecule, more the space it will occupy, and it will cause more and more viscosity. So that's why pentameric configuration of IgM increases the plasma viscosity. Hence, increased plasma viscosity is a feature of Waldenstrom, not much in multiple myeloma. In these patients, hepatosplenomegaly or lymphadenopathy, that means organomegaly is a feature. Organomegaly is not a feature of multiple myeloma. And cryoglobulinemia, which can lead to Raynaud's phenomena, is the feature, and that is usually not seen in multiple myeloma. The key word to remember here are hyperviscosity, hepatosplenomegaly, cryoglobulinemia are the four keywords that you got to remember in this particular slide. So to differentiate between the two, multiple myeloma and Waldenstrom, they have lot close resemblances there, but still few points. As I told you, in multiple myeloma, bony pains is the classical presenting feature. In fact, one of the most common presenting feature of multiple myeloma is bony pain, and this pain is absent in Waldenstrom. But you will be surprised, in the question also they talk about headache and blurring of vision. This headache and blurring of vision, this occur due to increased plasma viscosity, persistent headache. So here patient come with a headache. In contrast, in multiple myeloma, he come with a low backache or the leg pains. So site of pain is different. Organomegaly is a feature of Waldenstrom, the point I mentioned, and remember in Waldenstrom in multiple myeloma, organomegaly is not a feature, but benzone protein is present in both, including multiple myeloma, Waldenstrom. And just to add on to your knowledge, Waldenstrom, this benzone protein is also there in some patient of chronic lymphocytic leukemia also. Benzone protein can be there. So in nutshell, a quick recap. In multiple myeloma, pain occurs where? Low backache or legs. In Waldenstrom, pain occurs where? Headache. In Waldenstrom, headache occurs due to what? Hyperviscosity syndrome. In multiple myeloma, bony pain occurs due to what reason? Lytic lesion. Benzone protein is there in Waldenstrom, multiple myeloma, and chronic lymphocytic leukemia. Remember, organomegaly occurs in Waldenstrom and no organomegaly in multiple myeloma. Acute, other option, look into other option, acute myeloid leukemia. In this patient, benzone protein is not seen. Multiple myeloma is incorrect, lytic lesion are seen in multiple myeloma which are not there in our patient. Okay. And Burkitt lymphoma, younger age group is involved, jaw is involved, and M protein anemia is not a feature. In fact, IgM protein is increased in Waldenstrom. None of the conditions which are mentioned at the option IgM level are not increased in any of them. Of course, IgA and G can be increased in multiple myeloma. So we can vary by rule out technique also we can rule out, and of course we have many additional features which really say that none of the diagnosis is quite near to Waldenstrom macroglobulinemia. Myelodysplasia, again IgM level are not increased. The answer is Waldenstrom. Question 2, we are getting a 74-year-old male, frontal headache, blurred vision for the last 4 weeks, worsening fatigue, shortness of breath, anemia is there, ESR is 50, not very high. In multiple myeloma, the ESR may be as high as more than 100 also. Enlarged lymph node, spleen, likely diagnosis, Waldenstrom. Looks little easy, but let us see the analysis. Well, again the same line, Waldenstrom macroglobulinemia, they have feature come with the hyperviscosity. That's why this gentleman has got frontal headache. That's why his visual disturbance. This is all due to increased viscosity in the blood. So let's talk a little bit more detail about basic concept about Waldenstrom macroglobulinemia. First is the immunology. Increased IgM paraprotein is a distinguished quality. So if you are getting IgM paraprotein level increase, paraproteinemia what call, 99% you are dealing with Waldenstrom is a golden line to remember from immunology. So let's correlate this high protein with the clinical medical size. Headache is there. Visual disturbance because the retinal vessels they are congested. So they have a reduced blood flow, reduced velocity is there. Reduced blood velocity is there and that lead to visual disturbance. In rare cases, even stroke and ischemic organ damage can be there. But these two are very invariably in the exam or viva, they will talk about these 2 points. Feature of hyperviscosity syndrome, frontal headache in particular, and visual disturbance. Let's look into other option. Option A, Hodgkin lymphoma. In Hodgkin lymphoma, lymphadenopathy can occur, splenomegaly can occur. Okay. But thrombocytopenia is not a feature of lymphoma, and of course there are no feature of secondary to hyperviscosity. Hyperviscosity feature like blurring of vision and frontal headache, they are not seen in lymphoma. In multiple myeloma, bony pains are there. They are not associated with organomegaly, the point which I discussed in the previous question also. So spleen palpable, cervical lymph node palpable, enlarged, this automatically rules out multiple myeloma. Acute myeloid leukemia, it does not usually, doesn't lead to lymph node or splenomegaly, is not a common feature. Okay, not a common feature. And moreover, symptom of hyperviscosity are not there. Including ALL, in ALL lymph node spleen may be enlarged, but symptom of hyperviscosity will not be there. Moreover, these two, even the ALL is a disease of the young people below 10 years. It's already ruled out. Anyway, feature of hyperviscosity, frontal headache, blurring of visions are not seen in any of these conditions. Question 3, 70-year-old, deep vein thrombosis, recent weight loss, IgM level is increased. Well done, Tom. Now you notice that in any series, first question gives a lot of weightage. By the time we are ending second, third, fourth question, now the subject starts looking very easy because your basic concepts are strong. With this, you can answer any question throughout the world. So IgM level is increased. That is a scene that we see in well done, Tom. Let's look into other options also. So, well done, Tom. What about monoclonal gammopathy of uncertain origin? What in short we write as MGUS. But in MGUS, there is some increase, but they don't have weight loss and they don't have deep vein thrombosis. They are not seen. They are not seen in MGUS. These two are the feature of hyperviscosity, including deep vein thrombosis, which occur in Waldenstrom, not in MGUS. And IgG and IgA, they are produced in multiple myeloma. So this option E also ruled out. Option E also ruled out multiple myeloma. Remember, in question IgM level is increased, other immunoglobulin are in the normal range. Acute promyelocytic leukemia, here DIC, disseminated intravascular coagulation, is the feature. Raised IgM is not a feature. Okay. Antiphospholipid syndrome. It is seen in young females suffering from SLE. It's not a disease of the very elderly person of 65 years. Thrombosis is common, but raised IgM is not a feature. So point to be noted, in this lady, there can be deep vein thrombosis, but again the age is important. One thing is very clear, all the lymphoproliferative disorder, they occur in the elderly people. So at such age rules out antiphospholipid syndrome also. Friends, golden line to remember. How to differentiate between multiple myeloma and the Waldenstrom macroglobulinemia. Organomegaly, no, yes. This slide is worth $1 million. Bony lesion, yes, no. Paraproteinemia, IgG or IgA is IgM. Lovely slide. Make this, you must note it down. If you remember this slide, you are worth, out of this also, this is the single most important word. Don't forget this. Don't forget this. So friends, golden line to remember that. Golden line to remember is golden line, increase IgM, organomegaly. Equal to Waldenstrom macroglobulinemia. So golden line to remember, increase Golden line to remember, increased level of IgM and organomegaly is Waldenstrom macroglobulinemia. The whole thing is just squeezed into 2 words, golden line to remember. I hope you are much wiser about this topic. Well, lymphoproliferative disorder part 3. Again, I'll be using all these subspecialties which are relevant to my talk in this section now. We got question 1, some undifferentiated neoplastic cells. They resemble their embryonic counterpart. Oh, now we have to deal with again embryology. They elaborate some protein which only express in the embryonic or fetal life. One type is tartrate resistant acid phosphatase. Most likely, we got one patient with TRAP positive, but he didn't ask what the likely cause. He simply said, what can be the presentation? Lovely question, beautifully framed question. Fatigue and easy bruising. What is this? So for that we have to learn embryology, we have to learn oncology also, oncopathology also. So this question is discussing about the tumor markers, some of which are normal embryonic products. Point to be noted that we know very well that many cancer they have a tumor marker. Some of them may be produced by the normal in embryonic phase, but embryonic phase normal, but in that adult phase that become a marker. Okay, so one of the tumor marker which is there normal in a embryonic cell but abnormal in adult is TRAP, tartrate resistant acid phosphate. This positivity is indicated of hairy cell leukemia, is the golden line to remember. Right? Golden line. TRAP positive is 99% is hairy cell leukemia. So let's learn some basic concept about hairy cell leukemia. It's a rare, we'll talk about oncology part. It's a rare tumor of B cells. Point to be noted, again a B cell, which is the feature of all lymphoproliferative disorders. More common in males, much more common in males. Features. Here the bone marrow is involved. Point to be noted, it's the bone marrow involvement, not the bones as such, what happened in multiple myeloma. So it's not in the bone, it's the bone marrow is involved, and that lead to pancytopenia. Something very interesting to talk. Again, let's correlate this with the pathology. Leukemia, in general, when we talk leukemia, we just presume there will be increase in the number of WBCs. Okay. In general, it is very talking leukemia means we expect the WBC count to be very, very high. But this is something very amazing, alarming. We are getting hairy cell leukemia, but we are getting pancytopenia. That means there is reduced RBC count, reduced platelet count, and reduced WBC count also. All R, P, and W all are reduced. So due to this reduced RBC, anemia will be there, and that lead to fatigue. Platelet count reduced, that is patient is prone to bruising, and the WBC count is there, they are prone to infection. So we are clear about it why fatigue and bruising will be likely to occur in these patients. Massive splenomegaly is a feature, very, very important point. Vasculitis is there. What we see in vasculitis, erythema nodosum. Erythema nodosum is seen in these patients, which is seen in the shin area. Dry tap, this is again not known to 99%. In this, the bone marrow is hypercellular. Large number of cells are there. But dry tap, if you do the bone marrow aspiration, you are not able to tap. Why? This is the bone marrow. A large number of cells are there. Plenty of cells are there, but they are separated by strong fibrous tissues. So when you do the bone marrow, you are not able to reach up to the cell because they are all being covered by the strong fibrous band, so you get a dry tap. And hypercellular marrow, and classically they stain with tartrate. Trap positivity is the hallmark of hairy cell leukemia. So friend, the key word to remember are pancytopenia, massive splenomegaly, erythema nodosum, dry tap, hypercellular marrow, and trap positivity. These are the few words that you got to remember in this particular slide. So trap positivity is seen only in hairy cell. It's not seen in any of the other B cells. So that means it becomes exclusive. It becomes moon among the stars. Something unique, exclusive is always a diagnostic feature. Well, we always do flow cytometry. In flow cytometry, the best diagnostic tool, you get CD25, 103 and 11C positive. This you should remember. Can't afford to forget this. Cannot afford to forget trap positivity. And CD103 is exclusively in hairy cell leukemia. So friend, these are the key words that you got to remember in this particular slide. 1, 2, 3 and 4. These are the 4 keywords that you got to remember regarding the hairy cell leukemia. Other options in enlarging moles. This is seen in melanoma. In melanoma, the mark, of course, this is seen in the skin. In melanoma, the marker is S100. You should remember this. Of course, no need to say melanoma are usually seen in the skin and they are enlarging. But the biomarker is S100. It is not the biomarker that trap is not a feature. Similarly, focal weakness. This is due to neuroblastoma which occurs in children. So our patient is an elderly person and the marker is Bombaysin is the marker. So this is again not the option. Moreover, children, the disease of children and lymphoproliferative disease, they occur in the elderly person. Jaundice may be a feature of hepatocellular carcinoma. And the tumor marker, oncology part is alpha fetoprotein. We are well aware in hepatoma, alpha fetoprotein level are increased. So trap is not increased in hepatocellular carcinoma. And of course, jaundice will occur anything which is usually related to some liver pathology. Pencil thin stool, this tend to occur in colorectal cancer. Okay, in colorectal cancer, CEA, the carcinoembryonic antigen level are increased. So friends, a beautiful question on pure oncology and regarding the tumor markers. So we can say every tumor has different marker are there. So trap is different, Bombaysin is different, and the CEA is different tumor marker, and of course no need to say trap is a feature of hairy cell leukemia. Question 2. All are true about hairy cell except splenomegaly is conspicuous. Yes, it is massive splenomegaly. What do you mean by, let's talk about clinical based question. Let's convert this into clinical side. What do you mean by massive splenomegaly? This the abdomen, this the umbilicus. If the spleen tip is palpable, we call it mild enlarged. If it come up to the umbilicus, we call as massive splenomegaly is there. If it is somewhere in between, then we call as moderate splenomegaly. In these patients, you get massive splenomegaly, so it is true. Expansion of neoplastic T cell, no way, it is a B cell problem, not a T cell. Rule out, so this is not true. Cell are positive for TRAP, yes, they are positive for TRAP, we discuss. CD25, yes, we told you, because CD25, CD 103 and 11C, they are, we can see in immunotyping, this is true. Asthma nodosum seen, it is true. So we are very comfortably, by rule out technique only, we can say that this is not a T cell. This is the exception. All are true except this. Okay. So hairy cell leukemia is a B cell leukemia, not T cell. Question 3. Certain anti-neoplastic drug in a patient with a rare condition is an analog of adenosine, which reaches a high intracellular concentration due to resistance to adenosine deaminase drug. This is a question based on oncology, pharmacology also, and biochemistry also. Let's correlate the three. Answer is cladribine. So let's talk more about oncology and the pharmacology. Oncopharmacology, answer is cladribine. So let's read more about the pharmacology of cladribine. It's a pure analog, purine analog. Okay, it's a drug of choice for hairy cell leukemia. Just to add on to you, this cladribine is a recent drug, couple of years back, but before that we were using is interferon alpha. But nowadays cladribine, the drug, is a wonderful drug, purine analog. And this drug is resistant to degradation by adenosine deaminase. They are not affected by adenosine deaminase. Now, what is the normal biochemical reaction? What is the normal biochemistry of adenosine deaminase? It serves in the purine disposal pathway. And this enzyme degrades chemotherapeutic purine analog as well as adenosine. Okay, so it is going to degrade adenosine, everything. Now, cladribine being this resistant to action of adenosine, so they use cladribine for the treatment of hairy cell leukemia. So now you are clear about it, that it is resistant analog. It is resistant of it is the analog of adenosine, but not degraded by the adenosine. That's why it can attain a very high inside the concentration in the cell, and that can damage the cell. Okay. Now, extra point, genetics. Some of these hairy cell leukemia, they have a BRAF mutation, that is V600E. Let's talk more genetics. So some of course, the cladribine is a wonderful drug for majority of patients of HCL. They respond very well. But little bit people who are not responding to this, for resistant cases, we use a drug vemurafenib, which is a BRAF inhibitor. So friends, cladribine is the first line drug of choice, and this we use only in resistant cases, not in a routine case. Let's read more oncopharmacology. Cyclophosphamide is an alkylating agent, and it is converted into active form by hepatic cytochrome P450. It has nothing to do with adenosine. Lomustine is a nitrosourea agent by DNA alkylation and cross bridge formation. It is used in mainly we use for CNS tumor. It has nothing to do with trap. And now come the gold medal question. Write down the answer. This drug, which is used in brain cancer, has a unique side effect. Unique side effect means, don't talk about, there are certain side effects which are seen in most anti-cancer drugs like nausea, vomiting, hair loss, etc. They're routine. When I say unique side effect, like hemorrhagic cystitis in cyclophosphamide, unique side effect. What is the unique side effect of lomustine? Write down the answer quickly in your copy. Write down. Well, the answer to this question is delayed bone marrow suppression. Simple bone marrow suppression is very common, but delayed bone marrow is a feature. What do you mean by delayed bone marrow? Here you give the drug, the bone marrow suppression occur after 6 to 8 weeks. In contrast to most of the anti-cancer drugs which can lead to bone suppression within a few days. So delayed bone marrow suppression is seen in lomustine, and one of the more drug which is quite related to this drug is carmustine. Both these drugs we use for brain cancer. Dacarbazine is a cell cycle non-specific methylating agent. It needs enzymic activation in liver to get converted into active metabolite. So again, it has nothing to do with original problem. Cisplatin is a platinum containing chemotherapeutic agent. Okay, it becomes hydrated to form cytotoxic metabolite with low chloride concentration, so it has nothing to do with adenosine. So none of this is the answer of this question. Okay. So golden line to remember, TRAP is a marker that can be used to distinguish between hairy cell leukemia from other B lymphocytes, which are TRAP negative. Only TRAP positive malignancy is hairy cell leukemia, is the golden line to remember. So, lymphoproliferative disorders, part 4. Again, integrated approach. Question number 1. 73-year male, fatigue, malaise, WBC count is very high. Cells are mainly small cell. Oh, very easy. CLL. Smart examiner. He gave you the diagnosis also. But he's very clever also. He says, okay, fine, CLL is there. What's the most common finding? Oh, he doesn't say finding, he says most common, enlarged lymph node. Let's talk more about this. Well, the correct answer, enlarged lymph node, is seen in around 87% patients who have symptoms. They have a generalized lymphadenopathy. That means lymph nodes are not confined to a particular place, but the generalized lymphadenopathy is there. In addition to that, patients are prone to recurring infection, abdominal discomfort, fatigue, enlarged liver or spleen. They are the additional features. Why these are features I'm going to discuss soon. Loss of appetite or early satiety, the person feels that he has no appetite, night sweat, Abnormal bruising is a late feature. It's not a early feature. So let's go back to this is a late feature. Priapism is a painful erection of male genitalia. Now I have a question for you to answer. Write down the answer. In which condition, hematological condition to be more precise, where we can see priapism? Write down the answer in your copy. You get 15 seconds to think and write. And those of my dear friends who will be watching recorded video must stop the video before you answer to write the question answer. Quickly write down. In which condition, hematological condition, you get priapism? Well, the answer is chronic myeloid leukemia and sickle cell anemia. Well, now one more question from entomology, microbiology question to be more precise. Tell me which insect can cause priapism? Golden question to remember. And I give a clue also. Well, there was a movie also based on this, because what they do, they catch the insect, they crush it, and that material is used as an aphrodisiac. Aphrodisiac, the term that increases sexual drive, but at the same time it can lead to priapism also. Well, the answer is Spanish fly. Okay. So we got additional question. We got question regarding priapism. Now, recurring infection can occur in this patient also, but the most common finding is enlarged lymph node. Abdominal discomfort can occur because in these patients spleen enlargement occur. So enlargement of spleen can lead to abdominal discomfort. Okay. Yeah. Splenomegaly is there in 30 to 50% cases. Lymph node enlargement about 80 to 90%. Hepatomegaly in 10 to 20%. That means lymph node, spleen, liver. Petechiae can be there. Pallor can be there. Why they occur? This beautiful question. Are there two words which I am going to discuss in the future question. So in CLL, they have a very large quantity of small white blood cell. In the pathology, we get small white blood cell, but there are many things which have yet not been answered. But don't worry, I'll be answering in the coming questions. Now in the question 1, which is the additional finding? Splenomegaly. Okay. The point I discussed in the previous question, edema is not a problem, fever is not a very common problem. Congested conjunctiva is seen in polycythemia vera, not in CLL. Thrombocytosis is not a feature, rather thrombocytopenia can occur. This can occur in polycythemia vera. So splenomegaly, as I mentioned in the previous slide, is seen, and of course liver also enlarged. So this question we ruled out, other options are not problem, right? Now come the lovely question. A 72-year-old elderly people, smudge cells are seen, marked lymphocytosis, and CLL diagnosis is made. Oh, why? Again, the examiner is very kind. He is asking little easy question, but he's smart. He says, investigation of choice, immunophenotypic. But before I really go, I want you to note it down, smudge cell. Friends, if you get the word smudge cell in any question, 99.9% you are dealing with CLL. It's a very simple thing to look into peripheral smear. But in the exam, smudge cell is CLL, and of course, is the initial test, which give a clue in addition to marked lymphocytosis. If you get these two words, smudge cell, increased lymphocyte, you are dealing with CLL. But for the most accurate test is immunophenotypic. So let's learn into this. So what is done? It's a very valuable investigation is flow cytometry, what we also call as immunophenotypic. Is the most valuable. That means you have seen this increase in the peripheral smear, you got a lot of lymphocytes, smudge cells are seen. But you have to confirm by flow cytometry. So when you do flow cytometry, they are CD19 positive. In addition, CD5 and CD23 are also positive. Point to be noted, this in fact CD5 is a T cell marker and CD19 is a B cell marker. The unique thing about is the one thing where we are getting T cell marker and the B cell marker, so-called co-expression is there. So we are quite sure that if we are getting flow cytometry is the one. What about other investigation? Bone marrow biopsy, ultrasound, they may be helpful, but they are of additional value. They are not diagnostic value. Okay. And in this patient, recurrent infection are there because these patients they have reduced immunoglobulin level. So that lead to increased infection, but they are not going to diagnose. The diagnosis, and remember, increased infection, which I mentioned in the previous question also, can induce fever also. So this is a finding, but not a very common finding, is a late finding is there. However, as far as diagnosis is concerned, flow cytometry or immunophenotyping is the diagnostic technique. Okay. So CLL, now let's talk about pathology and pathophysiology. They are called by, again, monoclonal proliferation of lymphocyte, which are almost B lymphocyte. So point to be noted, this also just like monoclonal manifestation that we see in multiple myeloma, here also is a monoclonal B cell. But remember, in multiple myeloma, no liver, no spleen, no lymph node enlarged. But in CLL, everything is enlarged, lymph node enlarged, spleen enlarged, liver. All are enlarged. In liver enlarged, spleen enlarged, and lymph node enlarged in CLL. So we do investigation, full blood cell count, which will increase lymphocytosis, anemia. Smudge cell, the classical, the point which I emphasized in the previous slide, also known as smear cell. What is this? It is such an important clue. I'll show you picture also. Look into this. This is smudge cell. What is done? That in this, we know that in CLL, we have got lymphocyte count is increased. So you make a slide and you keep a cover slip. The moment you keep a cover slip, the leukemic cells are so fragile, they are crushed by even placing the cover slip also. So now you can see it is all broken. Broken cell is there, crushed is there, right? So it is because this is called smudge cell is there. It's a strong indication that we are dealing with CLL, but you confirm by flow cytometry. So I told you the clue, but this is the immunophenotyping, also called flow cytometry, is the diagnostic finding. Question 4, in the previous question, which the most likely pathophysiology? Now the things are very clear to you. Monoclonal proliferation of B lymphocyte. Okay, I think straightforward. But let's look into other options also. Is it polyclonal? No way. It is monoclonal. Out. Monoclonal proliferation of large granular? No. It is always the small B lymphocyte, not the large cell. Monoclonal T lymphocyte? No way. It is B cell. Polyclonal T cell? No way. So I think it's a simple question because your basic concepts are clear. That is why I've been in all my tests and discussion, everything I start with basic concepts. So by the time you are near the end of the test, you're already smart enough to answer any question. Okay. Question 5. 74-year lymphocytic leukemia, CLL, HB 7.9, very severe anemia. Platelet again on the lower side, high, small lymphocytes are there. Which complication can occur? Warm autoimmune hemolytic anemia. This is a universal question asked in all the exam. This needs discussion. We'll spend time. Well, in due course of time in CLL, warm autoantibodies are produced. So before I talk more about, let me discuss more about, little bit about warm autoantibodies. What are these antibodies? They act best at 37 degrees centigrade. They are IgG and they lead to Coombs positive hemolytic anemia. Okay. So these are antibodies are there. So this is seen around 10 to 15% cases of CLL, right? Well, this staging is essential. And I'll correlate this pathology with hematology, with clinical science. So we have stages of CLL. In stage 0, increased TLC count is there. Stage 1, lymphadenopathy occurs. Stage 2, spleen occurs. Splenomegaly occurs. Stage 3, anemia, and stage 4, thrombocytopenia. This is a very simple, and throughout the world, whichever exam you appear, your question will be based on this particular slide. So since a very, very important slide, so I'll be discussing lot of things, pathology, physiology, pathophysiology, pharmacology, medicine, etc. I'll be discussing in this. First of all, point to be noted, the staging start from 0. It is not starting from 1, 2, 3, 4, 5. It is 0, 1, 2, 3, 4, 5. Point to be noted. Point to be noted that when we are talking about increased TLC, then lymph node and then splenomegaly. You remember, lymph node enlargement was the most common finding seen in around 80 to 90%. Splenomegaly was in about 50 to 60% cases. So that justified the staging with the clinical finding. These three, they are the part of disease process as such. But in due course of time, these patients, they develop autoantibodies against the RBCs and the platelet, P for platelet. So due to that warm autoantibody, they tend to destroy the RBC. They lead to anemia. And still later on come the antibody against the platelet. They lead to thrombocytopenia. So thrombocytosis is not a feature, point number 1. Number 2, these two findings, they are occurred due to autoantibodies, which are warm autoantibodies. So now we are clear about it, why they are going to produce warm hemolytic anemia. One more thing, up to this stage, up to stage 0, 1, 2, which I said was a disease process as such, we'll be using some chemotherapy. But once the patient develops anemia, thrombocytopenia, is a high time to add corticosteroid. CS stands for corticosteroid. So the question can be asked this way also, which of the following is an indication of adding steroid? Anemia or thrombocytopenia. Why? It is an autoimmune process going on, and to take care of that autoimmune process, we add steroid. Otherwise, up to this stage, there is no indication of adding corticosteroid. Question number 6, we are getting a 60-year-old man, fatigue, weight loss, lymph node enlarged, spleen large, TLC count is very high, hemoglobin is low, peripheral smear is made that shows, oh, we are getting lot of smudge cells are also seen. Okay, smudge cells are also seen, and we are getting lot of cells are there. What is the normal function of the abnormal cell? Oh, he's saying large number of cells are there. What's the normal function? They are lymphocyte. They produce immunoglobulin. They are concerned with humoral anti-immunity. Okay. So we are quite clear about it. So let's look into other options. To activate cytotoxic T lymphocyte or B lymphocyte by co-stimulation, no way. It's not the function of small lymphocyte. Engulf bacteria, no way. Small lymphocyte they are not phagocytic cell. It is the neutrophil or the macrophages. To recognize antigen and virus infection, again, they are the function of antigenic presenting cell of T cell. This is not a job of small lymphocyte. Primary mode of oxygen transport, no way, that is done by the hemoglobin. So by rule out technique also, we are very comfortable that we are dealing with the option A is the best answer. Question 7. 77-year-old male diagnosed CLL and admitting getting 4 times for pneumonia. Most likely cause hypogammaglobulinemia. Why this answer? Why not others? Let's look into more detail. Then at the same time, we'll also rule out what the other technique. Okay. So remember, in the previous question also we talked about the lymphocytes which are concerned, which are going to get converted into plasma cell, which are going to make the immunoglobulins. Here the cells are all abnormal, or all cancerous cell. With the result, the amount of cell getting converted into plasma cell will be reduced. So they will reduce good immunoglobulin. So hypogammaglobulinemia occurs because they are not getting converted into plasma cell. Remember, in multiple myeloma, it was a disorder of the plasma cell. They were producing large amount of immunoglobulin, but they are all useless immunoglobulin. So good amount of immunoglobulin was reduced in multiple myeloma also. Here, these lymphocytes are not getting converted into plasma cell, the immunoglobulin level are reduced. That's why these patients are prone to recurrent infection, which can lead to fever, the point which I mentioned in the previous question also, that why fever is there and why recurrent infection is there. Hypersplenism is not a feature of CLL, no way. Decreased lymphocytic survival, no, it is not about survival, it is about the abnormal cells. Cancerous lymphocytes are getting produced. Transformation into high-grade lymphoma is not a feature which can induce to pneumonia. Is not due to lymphoma. Immature lymphocyte is not a feature. We are getting more of a abnormal small lymphocyte. So beyond doubt, this is the best answer by ruling out other options. The golden line to remember is smudge cells are seen in peripheral smear of CLL. So as I said, if you get smudge cell, you are 99% you are dealing with CLL. The next test and discussion will be on Saturday, 13th March, 2 p.m. And the topic will be lymphomas. Well, as my other tradition goes, whatever tests many of you are watching live now, many of you will be seeing recorded. Same thing, those who have missed the previous one, you can very well go to YouTube and see all the previous tests. But one thing is there, what have been discussed, they are the universal question applicable to all the exam. Why? Basic concepts have become very clear. And today every examiner wants your basic concepts should be clear. They are the previous tests I have done so far: acid-base disturbance, electrolyte, pharmacology of antiarrhythmic drug, pharmacology of antihypertensive CHF drug, hemolytic anemia, PNH, hemato-oncology part 1, part 2, okay, which I did. So all these are available, you can very well see in the YouTube. Well friends, I am launching with special course Smart Medicine. They are the recorded lecture of the whole medicine in this approach, including everything A to Z. 300 plus hour of recorded lectures. You don't need to read anything else. Everything has been covered up. Whatever relevant to all 19 subjects have been covered. Like today also I covered embryology, immunology, genetic, medicine, pharma, oncology, radiology, pathophysiology. It's like this wherever. In the topic of HIV, I covered 18 subjects, A to Z. If you read, you don't need to read anything else in that topic. And you can appear for any exam in the world. Okay, like what Harrison is the ultimate book of medicine, no doubt about it. Harrison contains everything. But it's too vast. It's not possible for a student to read Harrison. So the summary of Harrison is given to you. You read any one topic. Remember, just reading one page of Harrison, you need 30 minutes. 30 minutes you need to read one page of Harrison. To understand, you need 2 hours. That means to only read one page and understand one page of Harrison, 2.5 hours. But you need only 2 minutes to forget what was written in that page. That means your 2.5 hour hard work is washed out in 2 minutes. Solution I have come up. Summary of Harrison is there. Ultimate notes are there. You can very well take the free videos of these. For that, you just contact my staff at this number. I'm enlarging it. You can write it down. Or this is my staff number. You can very well contact me also in my personal email ID. It's easy, dbmi@dbmi.edu.in. I hope you can note it down. You can very well request. My staff will be sending you videos. You see and you read one topic and try to do whatever subject, whichever exam you are appearing, do the question. You will find majority of question, 95% question you can do of all subjects. Ultimate are these. Okay. You are well aware I have already written a book of Mini Harrison. Its name is Harrison Simplified. It is available in Amazon also, ultimate book. I always say Harrison is the best book, but you cannot read. You need a shorter version, is Mini Harrison. Okay. My aim is to convert you from a simple star to the moon. There are millions of stars, but there is one moon is there. That is you. Thank you very much. God bless all of you. I hope you like the session. Do give the feedback at the email ID I mentioned to you. Okay. Thank you very much.